What is up, everyone? Welcome back to the Critical Care Lounge. I'm here with the one, the only, the Green Machine. Adam, what is up?
Not much, Annie. Thank you. We had a long break this time, 2 weeks instead of the normal 1 week off, right? How you feeling?
My fault. Long week in the ICU, and I just couldn't get out of the hospital in time. But the good news is, in the meantime, you got a new camera, and I had no idea that you were blonde this whole time. With the last camera, it was hard to tell.
Blonde, reddish tinge, a lot of it's missing, but there's some hair there.
Oh, that's all right. I had to wear a hat today because it was too crazy under there. All hair is excused on the Critical Care Lounge.
Yeah, you've been looking a little fluffy lately.
Yeah, we gotta get the old locks back in shape. But
that's right.
But regardless, we're here tonight, and we have two awesome guests. I'm going to turn over to Adam to introduce them.
Sure. So I feel like each week I'm more and more excited about who we have to talk to, and this week's no exception. So we have two of our neurointensivists from Cooper, Fred Rincon, Dr. Fred Rincon. Hey Fred, how's it going? Head
Good,
of the
how are
IC, you? I'm great. I'm good now. And here we go, Dr. Swarna, and I'm going to try really hard. Rajagopalan, how is that? Good enough, right?
Swarna, I think you're muted. We can't really hear you.
Oh.
And I think Rajagopalan, it's Italian, I think.
Yeah, definitely Italian. Classic Italian
Rajagopalan.
Rajagopalan.
Would you do
anyway,
this?
Thanks for
with your
coming.
hands? Everything is Italian.
Exactly.
So Hanny, what are we talking about tonight?
Well, this is something we've wanted to talk about since the beginning, but there are so many topics, and finally I'm glad we get around to talk about status epilepticus. I have a theory, and my theory is there are a lot of doctors who think they know what status epilepticus is, but they actually have no idea what status epilepticus is. And that is because the neurologists keep changing the definition. So every time I think I know something, they change the definition. So once and for all tonight, we're going to get it right, okay? I'm going to start off by asking the question that everyone wants to know. There's a two-part question, but what is the textbook definition of status epilepticus? And then what is the definition when you're at the bedside and the patient's seizing and you're like, oh, crap. I want to know those two definitions. Are they one the same? I doubt it, but please let us know.
Go for it, Swarna. Textbook definition.
The textbook definition that's also changed, but the textbook definition used to be uncontrolled, continuous, convulsive or non-convulsive movement for 30 minutes. So you can imagine why that definition we don't use anymore, because a lot of brain damage happens in 30 minutes. So the textbook guideline definition's been updated to 5 minutes of either continuous seizure or 2 seizures without return to baseline.
Now, that's the definition that you have at the bedside when things are falling apart, or is there even like 5 seconds after I give Ativan? Fred, why don't you tell us, what is the bedside definition?
Yeah, so as Swarna was saying, that's sort of like a bedside definition. My bedside definition is a little bit more aggressive. Anyone that has had a seizure that is not returned to baseline is in status until proven otherwise. And when I say that, it just basically pushes me to either rule in or rule out the diagnosis. So I'm very aggressive at trying to exclude that diagnosis. I want to make sure that I'm not dealing with somebody that is seizing subclinically. So that's what I'm saying. You see somebody seizing, not back to baseline, rule of thumb is in status until proven otherwise. That means that you have to throw a probe, like in shock. You have to make sure that the pump is working. Same thing with the brain. You have to make sure that it's working. And if it's not working, if it's because it's seizing, then you have to make that diagnosis.
Fascinating.
All right, I like it.
Yeah, let me help me a little bit, because I feel like we're rounding in the ICU. We see the patient. They're encephalopathic, right? And someone says, oh, they could be seizing. And I feel like it happens all the time. We order an EEG. They're not seizing. So which patients are the ones I need to be concerned about? And it can be non-convulsive. We'll just focus on which patients are we concerned about? How does status normally present in that setting?
Yeah, Adam, that's a great question and a tough one. One of my mentors early in my training, Pete Crino, he's now the chair of neurology at the University of Maryland, always taught me that you can't tell someone who is in continuous non-convulsive status looks exactly and can look exactly the same as someone who is not. And it's really, really important to get electrographic data on these folks. Now, what will raise your suspicion that this is probably truly epileptic status? A few clues. Any facial twitching is highly specific for epileptiform, for it to be coming from the brain. Any eye opening has a high specificity. I would say that apart from those two things, gaze deviation, nystagmus, those things can suggest seizures. Apart from those things, it's hard to tell when someone's already either has decreased level of arousal and is sleepy, or is confused, because they could be postictal, they could have just had a seizure. It's sort of hard to tell. But facial twitching is super highly specific. So if you ever see that, have a really high suspicion that it's epileptiform.
Got it. Let me ask you a question, and it's just the four of us here. There's no one else listening. If you're in an academic center, right? Okay, come in closer. I have a question. So in a perfect world, right, in an academic center, how fast should you be able to get a stat EEG? I won't tell anyone what you said is your answer, but what should really be the truth? Because I find that I have to take someone to a very nice dinner and then to a movie afterwards if I want to get a stat EEG done, even in an academic center. Hypothetically speaking, of course.
And can you answer at noon and at midnight?
Yeah.
Well,
and then Christmas Eve on a Saturday.
Well, I'm glad that you asked the question because it has been scientifically answered. Okay, so the Bedside study, for example, gives a clue of how much time it takes in an academic center that is specialized in doing continuous EEG for patients, with seizure activity. It takes about 4 hours to get a continuous EEG. So, that study was a multinational study. Yale was one of the primary centers, and Yale is a center that does a lot of continuous EEG in critical care patients. And at that institution, for example, the median was almost 4 hours. So it's incredible. So when you look at the status guidelines, right, that suggests that you need to do continuous EEG in somebody with suspected non-convulsive status within 15 minutes, it just doesn't make a lot of sense.
And can I ask, does continuous EEG miss some status, or is it pick it up 100% of the time?
No, because it's a interpretation by somebody. So it really it's user dependent. So it really depends on who is reading the EEG. So the sensitivity, the specificity, and the bottom line, the accuracy really depends on who is reading the EEG.
I have a question.
Yeah, and remember. Sorry.
Go ahead, Swarna.
I was gonna say it's a surface EEG monitor. So scalp EEG for focal seizures that don't have a large field of depolarization, you can miss 30% of focal status on scalp EEG. So that's a huge number.
Yeah, that's significant. All right, so let's get back into the patient who is obviously seizing in front of you. So they're seizing, they're in status. What I want you to walk me through the neurointensivist approach to status. I always learn benzos, sometimes a little more benzos. Is it Keppra next? Is it phenobarbital? Can you give me some guidance on what you do at the bedside when someone's in status? What's your first medication and what you do when they fail? Just give me the whole chain, because I think that's very helpful. We know that time is brain. Or is that a different disease? Well, we just know that we need to get the seizure stopped as quick. Neurologists always like time is brain for everything. But my point is that I want to know how to quickly stop the seizure effectively, and I want to know from you what the sequence of events I should be doing is.
Go ahead, Swarna.
Yeah, so how I approach this is um, a nice dose of benzos. So zero point 0.1 mg per kg. So, in a 100 kilogram individual, that's 10 milligrams. So that, that underdosing that from the get-go can lead to prolonged seizures. So I would give a nice zero point 0.1 milligram per kilogram dose of benzos. My preference is usually Versed, and Versed Ativan doesn't matter. Whatever benzo you can get your hand on. I would start with that, and then if the seizure is not aborting with that, I usually chase that with. I'm assuming that airway, breathing, circulation, all of those things are taken care of. But if not, I would set up to take care of those things. And then probably I usually do another big push of benzos until seizures stop. Again, a nice dose, so zero point 0.1 milligram per kilogram dose. If it doesn't stop, I move quickly. At this point, I'm pretty worried, right? Especially if it's convulsive status and it's really not responding to really big doses of benzos. I move on right away. I order like an anti-seizure medicine, but typically, practically, it just takes a while to come and give that, and it takes a while for them to respond to that. So if it's continuous convulsive status, I'm pretty worried. I move on to a sedative right away. The textbook answer is really to load them with an anti-seizure medicine, which let's say I've ordered and pharmacy hasn't verified it yet, or it's, someone's getting it and it's mixing a bag, takes a while. If all of that's going to take, 30 minutes, that's really not practical. So I move on. If they're in convulsive status, I move on to a IV sedative pretty quick.
What you, Fred?
Yeah, I agree with Swarna. You have to load them with a hefty dose of benzodiazepines. There are several studies out there, clinical trials that show how, for example, midazolam and lorazepam are superior to other ones at controlling seizures in status epilepticus. So those are the first two agents that you should always be thinking at the right dose, either midazolam or lorazepam. The beauty of midazolam, right, is that you can also use it endotracheally. You can also use it intranasally. You can give it IM or intravenously, and you can also use it intraosseously in the case that you don't have access. And then the anti-epileptic. There are three choices. According to the guidelines. You have phenytoin or fosphenytoin, levetiracetam. And they seem to be equivalent in terms of controlling seizures. But the key thing is the dosing. You have to make sure that you give at least 20 milligrams of fosphenytoin or 60 milligrams of levetiracetam upfront to a patient in seizing. I like valproic acid also. A second agent is a gunshot, in my opinion. I think it's a great drug. When you're thinking about respiratory depression, if you use a lot of benzos and you use valproic as a second dose, you don't have that much of respiratory depression. Interestingly, right, fosphenytoin and lorazepam have a similar incidence of depression and side effects. So you could end up intubating somebody just on Dilantin that you're giving a hefty dose. So, if people ask me, I would say perhaps my second choice will be valproic if there's no contraindication. And then the third, if the patient is actively seizing. By the way, I've never seen patients clinically seizing more than a minute. So the definition in the textbook of 5 minutes of seizures, I've never seen anyone seizing for more than a minute, right? If you are, then the patient really has a bad, burst of epilepsy. But the third agent will be a drip. You have to think about, an anesthetic or some drip with an anti-epileptic activity. And then after that, you're talking about refractory status. You have to think a little bit more. More aggressive therapies that may require intensive care management and admission to the ICU, ventilation, etc.
That's great, Fred. So I have a question. So is it right for me to think that the benzos is my acute treatment to stop the seizure, and this anti-epileptic is how I prevent further, maybe similar to, beta blocker and amio to keep them in sinus. And with that, my question is, does every patient who gets benzos then get an anti-epileptic?
That
So
is
that's
what
a
I would
great.
be doing. Yeah.
Mhm.
Go ahead, Swarna.
Oh yeah, I was going to say that's a great question. It does somewhat depend on the cause. If you're talking about alcohol withdrawal seizures or something that's clearly provoked, many neurologists will say don't start an anti-epileptic drug. My practice is if I think the brain is irritated for any reason, I always start a drug, even if it's provoked. However, alcohol withdrawal seizures are a little bit different. Normal brain, well, as normal as their brain is, and the alcohol withdrawal seizures, I might skip the anti-seizure medicine. But with the exception of that, yes, I would always pretty much load them with a nice dose of one of the three medications that Fred mentioned.
And Fred, I just want you to think about this. Maybe no one's ever seized more than a minute because of the quality of neurologist you are.
Yeah, that was a straight up flex, Fred.
Yeah.
I gotta admit.
Yeah.
I mean, no one has ever seized for more than a minute. Well, Fred, okay. Thanks a lot.
Yeah. So when I
I've
see
had
a
a patient
patient for
seize
90
more.
seconds, I'm going to say,
Yeah.
damn, I wish Fred was
Damn
here.
it. No, I'm no
Got
Dr.
me again,
Rincon.
Rincon.
So close.
So close. So, that's great. But let me ask you a question because, I come from emergency medicine and, we're into algorithms and we want to know boom, 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 boom. One of the things that I learned during my residency was at some point in your algorithm, you have to stop when they're in status and think about two things. The first, well, maybe three things. The first is hyponatremia. Right, if the person's refractory to benzos. The second thing is if the person has eclampsia. And so, I mean, sometimes that's very obvious, sometimes not so obvious. And then the last thing is if they're INH overdose, right? And so I thought that those things were like, you drill into your head, you never see them. And then on the last day of my residency, no joke, we had an INH overdose. And I remember just drawing up the vials of B6. So let me ask you this. I mean, is that in your algorithm for the person that's refractory, or are those things just so rare that they're either so obvious or they just don't happen?
Fred,
Yeah,
go
those
ahead.
those are real, out of the box sort of like situations, weird situations. They happen when you're not expecting them. You train about it, you read about them, right? And then the last day of fellowship, they sort of like show up in your right in your emergency department. I usually think about causes of status, right? The most frequent ones first, and then the last ones are like the weird ones, as you're saying, right? If somebody continues to have seizures, but I don't know how long would a patient in status remain in the emergency department so that you start thinking immediately about INH poisoning. There may be some other things that you would see, in addition to just seizure activity, right? The metabolic panel in somebody in status have to be done within 5 minutes, so you could have clues about abnormalities in LFT, that sort of thing that could present as provoked seizures, right? That's a different type of patient population. The one that has never had seizures before and is just having an intoxication with something, it's obvious that as soon as you remove the toxin, the seizures are going to go away. Same thing for the preeclampsia case. You have to deliver the baby, and then the seizures would go away eventually. But yeah, you have to think about your possible causes.
Gotcha. It's good to know, though, that despite all of that, still never more than 1 minute for you. You've been able to consider all those causes in under a minute. This guy's truly amazing, folks. You're seeing a legend.
I'm saying clinical seizures. I'm not saying non-convulsive status.
We know,
right?
Fred.
No,
we
no,
know,
no,
Fred.
no.
We know. There's no backtracking that one. You're going to live with that forever. What do you got, Adam?
How about ketamine? What's the role of ketamine in status? I think we can ask that question no matter what the topic is. ARDS, you use ketamine? How about status, though?
You want to answer that, Swarna?
Nope.
You're mute. You're muted.
I think it says you've muted. So either do interpretive dance or let's find the button there. All right, maybe. Don't hear you yet.
All right, so I'll answer the ketamine. So
Answer what I want you to answer what Schwarna would say. That's what I want you to answer.
I'm gonna try to read her mind.
All right, go ahead, Fred. We'll get Schwarna back on here.
So ketamine, it's one of those tools that should be in your toolbox. As a critical care provider, you should have, if you're treating patients with refractory status, it should be part of your toolbox. And the reason is because it has a different mechanism of action than the regular medications that you're using regularly. Such as benzodiazepines, antiepileptics. Ketamine is anti-NMDA receptor. So it has a different sort of like, target at the time of inhibiting neuronal activity. So because of that, right, when I'm treating patients with refractory status epilepticus, once I am on that third level, which is usually midazolam in my algorithm, and I am already at 1 milligram per kilogram dosing an infusion per minute, I usually, move right there to ketamine. Before, we used to exhaust midazolam. The problem with that is that because of the dilution, if you think about how much midazolam you are giving at 3 milligrams per kilogram, for example, that's a hefty dose of fluids of about 150 cc. So, a couple of years ago, when we were treating status with midazolam, we would put patients in pulmonary edema very easily. They will go hypoxic because of the amount of fluid that we were giving. So we stopped doing that, and at 1 milligram per kilogram, we will actually continue the midazolam at that level, and we will start the ketamine. The issue with ketamine is that it has a lot of sort of like providers that want to control the use of ketamine in your institution. So the anesthesiologists are the ones that usually fight back and say, well, you cannot use it for status, right? There's not a lot of data, but there's a lot of data out there, and should be part of your toolbox.
And I'm assuming you're using the dissociative dose, right? The 1 to 3 milligram.
No, you have to use higher. That's how you start.
Ooh.
But you have to use higher doses up to 10 milligrams.
Oh wow.
Right. Yeah. So the anti-epileptic dose is higher than the dissociative dose.
Wow. So what's the initial dose if you're drawing it up? 10 milligrams right off the bat?
The initial dose in it should be like 1 to 3 milligrams, and then you sort of like go up 5 milligrams up to 10. I don't know if Swarna has used more than that. But most of the protocols out there that I have looked at, I think go up to 10. I don't know, Swarna, if you have more experience with higher doses.
Swarna, you're still muted.
She's still muted.
What? Did that
work?
work?
You go. Yes,
that works.
There she is.
Okay, woohoo. Okay, so I use 10 as the ceiling, and I usually start at 1.5 or something like that.
Okay.
Yeah.
Great. Any other tricks up your sleeve that you use for patients who are in status? I know ketamine's a darling, but what else do you have? So we're giving benzos. You may even go benzos. You're going levetiracetam. You guys have to say the trade name for Keppra before graduation, right? Is that part of the final exam? I don't know why I can't ever say it. I don't know why.
There's two types of people in this world, Haney, right? Generic and brand, and you're definitely a brand man kind of guy.
I got to be a brand man, Keppra. But then, we're getting into ketamine. Anything, valproic acid, Fred said he likes to use that. Anything else that might just not be on the tips of everyone's tongues? By this time, let's be clear. If you don't have a neurologist at the bedside or on the phone, that's a problem. But still, I still think it's good for people to think on their feet and know what to ask for. You might get an intern who comes down from neurology. So what else do you have up your sleeve for patients who are truly refractory at this point?
If you've already done benzos and ketamine, then
Mm-hmm.
I would use propofol.
So it's time to
And then,
intubate those people at that point.
oh yeah, yeah,
Yeah.
it's time to intubate these people. Propofol is next. And then, once you hit the ceiling for those drugs, you really have to ask yourself, what is going on with this patient? Is this something autoimmune? Is this something inflammatory? Should they be receiving steroids? Should they be receiving immunomodulating therapies like IVIG? Because it is really, I mean, Fred's
It's rare.
anything more than a minute, right? So
61 seconds for Fred. 61 seconds for Fred. Right. But for everyone else.
Exactly. For everyone else, yeah. So if anything's been going on for a significant amount of time, despite all those sedatives, you really have to ask yourself what's going on, and if it's
Right.
something more than just your garden variety, either provoked seizures or seizures from a structural cause, there might be something really irritating the brain. I've used inhaled anesthetics as a
Nope, you're muted again.
Oh, lost you.
Still muted. Well, while you're getting back on, I do have one question, and I feel like I'm hogging up all the question, but I'm sorry, Adam. Like, I got these
That's all right.
experts.
That's all
I
right.
want to pick their brain. Intubation is one of those things that, obviously before you even get to before you get to that fifth line, you're probably intubating those people. I personally think after benzos and maybe a dose of Keppra, you're going to intubate those people. I am a straight up Rocuronian person during my intubations, except for maybe one situation, and it's this situation where I want to use succinylcholine because I want my neuro exam back, right? I know that the EEG tech is coming in because I've offered to take them out for that steak dinner. So that's coming up soon. But the truth is that I want to get my neuro exam back to know if I need to keep doing some things. So my question is people always talk about Sugamedics as being a suitable alternative for that. I just want to pick your brain and ask you what you use should you have to intubate these people. So if you're doing the airway and you have to choose your induction meds and your paralytics, walk me through what you're using for this induction. Are you using propofol, for example, as your sedative? I'm just curious.
It's a really, really loaded question, Haney.
No, it's honestly there's
it-
you can answer however you like.
Yeah, so if it's purely just status and I'm not worried about ICPs, and they're hemodynamically stable or their blood pressure is elevated, then propofol and rocuronium would be a fine choice, or propofol and succinylcholine. If I'm worried about, it really depends on the situation, because a lot of patients in whom I'm worried about raised ICP, I do avoid sucks because of the depolarization and the muscle fasciculations that can raise metabolic demand in the brain and increase ICP. So, but then they're out longer and paralyzed longer. So it's, which one am I theoretically more worried about? Do I want a neurological assessment sooner on this patient? Or am I really worried about ICPs? That'll guide my neuromuscular blockade choice. And then also, what other neurological conditions do they have? Do they have any neuromuscular junction disorders? Do they have anything congenital, weird myotonias? So those all guide my choice and my dosage of neuromuscular blockade.
Cool. Fred, any difference?
No, same thing. You can do variations of your rapid sequence intubation depending on the patient physiology, hemodynamics, and the availability of lab work, for example. But Haney touches base on one important thing, is that, yeah, you're right. If you are paralyzing somebody, you're losing the best neuromonitoring available, which is the neurological exam, right? So if you don't have any choice but to use a long-term paralytic such as rocuronium, right? You have to get that EEG on top of the patient. And you were mentioning BIS, sort of like a surrogate, right, of continuous EEG. Yes, it could help you, right, if you sort of like get a 40 to 60, but it's not optimal, right? I mean, you may be suppressing, frontal areas only, and the focal seizures may be in the back. I mean, who knows? So it's not ideal. I mean, there are better options right now in the market. Point of care EEG is the one that we've been using more recently in the satellites at Cooper, and also at Cooper when we don't have availability, and then you get the answer immediately, within 5 minutes. And it has more channels. It has 8 channels from 10 electrodes, compared to BIS, which is only 2 channels, one on each side. But I've seen some papers from some of my friends in fellowship, using BIS sort of like a surrogate of EEG activity. But it's like if you ask me, right, about ultrasound, right? I mean, would you use a linear probe to try to, check the heart? The answer is probably, if you don't have any other option, but you won't get the information that you want.
Makes sense.
So it sounds like EEG is what you got to do. So get out your credit card and get ready to take them out to a steak dinner.
Yeah.
I have some questions from the audience, but Adam, I want to turn over to you because I just have one capitalizing on these guys.
Burst suppression. I feel like it's something you guys put in your notes just to confuse us. Are we always titrating to burst suppression? Is that always the goal? What's the deal?
Is there such a thing as burst suppression? Just so you know, is there really even such a thing, or is that like you're just saying that because we don't know?
No, there's such a thing.
It's just to mess with you guys.
I knew it. I knew it.
So sorry, I might have missed the first part of the discussion. I'm having some technical difficulties. But for burst suppression, was the question, when do we do it?
Yes.
Is it real?
Are we always doing it? Yes.
Okay. Are we always doing it? Great questions. So that there really is a huge variation in practice in management of status epilepticus. Some people, so this is a judgment call. If the times that I do it, I'll start with that, is when I'm treating someone for status and they're having epileptiform bursts that are so frequent and sort of angry looking, and I'm looking at them and I'm thinking, man, if I turn the sedative down just even the tiniest amount, they're going to cease. That patient, if they're already on sedatives and they are looking that angry, making me nervous to even back off on a little bit of sedatives, those are the patients that I'm thinking, okay, their brain just needs to be completely shut down. The other group of patients that I think about are when my go-to is always seizure suppression. I titrate sedatives to seizure suppression first. And if I've done that and then I back off on the sedatives and I'm, waiting for them to wake up and then they go back into status, those are the guys I'm like, okay, I've already tried a really good dose of sedatives and I've already tried this once and it didn't work. So let me try something different. And then those are the people that I then target burst suppression. And then when you start to burst suppress someone, the question is, how deep do you burst suppress them? Should you be looking for one burst and then 2 quiet, or one burst and then like 8 quiet? I don't know if you know what I mean by that.
Sense.
So like one burst, and then like the quiet period in between that precedes the next burst. So really that's another question. How deep should you burst suppress them? And I don't think anyone knows the answer. Oh, Fred might know the answer.
Calling you out, Fred. Calling you out.
Anyone really knows. Yeah, you're on.
No, so that's a great question. I think that which sort of like outcome or goal do you pick really depends on how aggressive you're seeing seizures on the EEG. What is the patient history? Is this the first one, the second one, third one, that sort of thing? Are we dealing with a super refractory status, that sort of thing? But in my opinion, I usually start with seizure suppression, which is I just want to target seizure suppression in the EEG, because burst suppression strategy is associated with a higher level of care. So meaning you're going to use more stuff. Hemodynamically, the patient is going to have more impact, from the amount of drug that you're using to achieve burst suppression. So it's something that needs to be considered. For example, an elderly patient, right, 90-year-old with an EF of 20%, please don't ever put him on burst suppression, right? You're going to like shut down that heart. You're going to end up with shock and you're not going to be able to treat the patient. Just target seizure suppression and see what you can get out of the treatment strategy. So it should be sort of like guided based on patient hemodynamics and physiology.
That's the first time I've ever heard a neurologist talk about the heart, by the way, just so you know. a true nerd. I'm just kidding. My best friend's a neurologist, so I can say that. All right, let me ask a couple questions because I think Sam Zarbi is going to jump out of the screen and punch me in the face. He's asked so many questions. I've answered none of them. So let me put one to you because this is actually one of the questions I was going to ask. What if you're worried about ICP? How to change your approach? And this is in reference to intubation. So I guess, do you do anything differently for those people? And I'll also add in the lidocaine. I mean, that's no longer a thing. Fentanyl, something that you can pre-treat people for to mitigate ICP. So what are your thoughts on that? Is it hogwash, or is it something that you worry about?
I worry about it. I think, in terms of anesthetic or sedative agents, I try to use something that will decrease the metabolic demand of the brain if they can hemodynamically tolerate it. So, propofol is a really good agent for that. Etomidate, if the converse is happening, their blood pressure's like on the lower end, if it's a stroke patient and a malignant stroke and raised ICPs from that, and I'm worried about their perfusion, then I might use etomidate. Ketamine, there's animal data showing raised CBF with ketamine, and raised CBF and raised blood volume, therefore raised ICPs. I have seen raised ICPs with the use of ketamine that I've used to treat status. And it's hard to parse out, the raised ICPs from the medicine itself or the status itself. But so it's hard. Ketamine I avoid if I'm really truly worried about raised ICPs. And then in terms of so those are the basic things that I think about with raised ICP. I don't know if you have other thoughts, Fred.
She was asking if I had any thoughts. So when I'm suspecting intracranial hypertension for whatever reason, the CAT scan shows cerebral edema, or I look in the eye and there's papillary edema, or I do a optic nerve ultrasound, right, and I see some evidence of cerebral edema. I try to be more careful with the blood pressure. I don't pay attention that much to the sedative. I would intubate with propofol and rocuronium in that case, but I would have phenylephrine ready to go in. I would perhaps pre-infuse the patient with some fluids because I know with the vasodilatation is going to happen after the propofol. And the bottom line with ICP in an intubation setting, right? Is that all these medications have been associated with elevations in intraocular pressure, intragastric pressure, and animal models of intracranial hypertension, right? Who knows if it does really mean something, that the pressure increases in the brain so much that the patient will herniate in front of your eyes. I don't think that would happen, right? In my opinion, the worst thing that could happen when you have intracranial hypertension is hypotension. So that's when I am really sort of like thinking about keeping it, at normal level. And by the way, the guideline for status epilepticus suggests that your blood pressure should be always MAP more than 70, systolic blood pressure more than 90. So for your intubation, you should keep that in mind.
That's incredible. So basically, Fred is treating the person, doing a cardiac echo, doing an optic nerve sheath echo, putting in an A line to measure the maps, all in 60 seconds, folks. This is
Under 60
unprecedented care.
seconds.
While they're seizing.
While there's no,
While they're seizing.
and then at that
Arms
50,
flailing.
and then at the 59th second, they stop. Phenomenal. Legend. Adam, what do you got?
You want to keep going through the questions, or do you want me to ask
Yeah.
them? What do you think?
Yeah, there's a couple good ones because we also want to stay on time here.
I like this question
we also
about
had,
focal status.
yeah,
Maybe
yeah. So
talk a little bit about. I think we mentioned briefly. Maybe talk about focal status. How does that change?
yeah, our questions must have leaked out because that was one of our questions that someone from the audience asked. So, Shwarna, do you want to tell us? Do you want to comment on focal status?
Yeah, so focal status is when a focal part of your brain is firing, but it's not generalizing, crossing over to the other side, resulting in, contralateral symptoms. So depending on which part of the brain's firing, if the parietal lobe's firing or the motor strip's firing, you might see jerking on one side. However, their awareness is preserved and they can have a conversation with you. So these patients, you're thinking, how deep do I go? How much, how do I escalate treatment in these folks? So I typically, I talk to the patient, and then I try and get an idea of how much it bothers them. If it's focal motor seizures, they're actually really hard to control. So I stop at 3 AEDs. And if any of the side effects of the anti-seizure medicines are decreasing their quality of life more than having the movements controlled, then I back off on it. So, So I talk to the patient, I have a conversation with them, try to figure out how much it's really bothering them, try to figure out how much it's interfering with their quality of life. I certainly stop at the anti-seizure medicines and don't move down the sedative pathway for those folks.
Got it. Great. Let me see what else we got here. This is a good one. What are the criteria or situations in which transfer out of a community hospital to a tertiary care center for continuous EEG are mandatory? Knowing full well that EEGs happen immediately in academic centers.
Mm-hmm.
Yeah, so just to answer the question, right? What is the pretest probability of somebody being in non-convulsive status epilepticus, right? And then the clinical exam can give you some basis to think about it, right? So stupors or comatose patients, right, suspect non-convulsive status. Within that category, patients with brain injury have the highest pretest probability of having status epilepticus, meaning, if you have traumatic brain injury, you have an intracerebral hemorrhage, a subarachnoid hemorrhage, encephalitis, meningitis, you name it, right? Those are the highest patients with the highest prevalence to have non-convulsive status if they are stupors or comatose. Any patient with encephalopathy, abnormal mental status in a medical ICU, and this has been, demonstrated in observational studies, have an incidence about 20 to 30% of having non-convulsive status. And then surgical patients, right, that are comatose stupors that are surfacing from anesthesia and are back to their normal mental status that also have a higher, incidence of non-convulsive status. So in the emergency department, right, if you're in a community hospital that doesn't have access to continuous EEG and it crosses your mind, non-convulsive status, and you don't have availability to rule it out, take the patient out, right? If you're in a MICU or in a SICU, right, and you don't have availability to do continuous EEG, right, and it crosses your mind that the patient is in non-convulsive status, transfer the patient. I mean, I cannot give any more expert opinion on that stuff, right? Because the treatment is so simple, and the more that you wait, the harder it gets to treat the patient, right? What is the alternative, right? That you convince your administration, your institution, that you need continuous EEG, and you get support from your neurologist or from the critical care people, right, that deal with this all the time, and then perhaps you can institute a program of point of care EEG. So those would be the recommendations. But if ever crosses your mind and you cannot make the diagnosis, I would argue ethically you'd have to move the patient out.
Now, I mean this.
Fred.
Oh, Go ahead, Adam.
Give me one.
Yep.
Okay, just real quick. Can you focus a little bit on that point of care EEG? I know it's a little self-serving, but maybe talk about what we did at Vineland and how we used it. Um,
Yes.
I
So
think that'd be helpful.
so there is technology out there available right now that you can use, right, to sort of like fill that gap that continuous EEG has because of whatever the infrastructure, the logistics that you have at your institution. So this technology out there developed, tested, and approved by the FDA called point of care EEG. I like to call it critical care EEG because that's exactly what it is, and is an alternative, right, to sort of like use a it has less channels, so it's not as continuous EEG, 2010 montage that you use normally in an academic institution, but it has enough sensitivity and specificity, right, that you can actually rule out, the presence of non-convulsive status. And there are three tools available within that technology, right? It has also artificial intelligence. You can look at the EEG yourself, or a neurologist can look at the EEG and sort of like comment on the possibility of seizure activity. But the most interesting thing is the artificial intelligence engine that it has, that is very accurate at documenting the presence of seizure activity. So if the machine is telling you there's seizure activity, right, then it can give you immediate opportunity to start treatment based on the guideline, right? And to either consider transferring the patient to a higher institution if you cannot deal with the full management of status epilepticus. So our experience at Vineland, which is a community hospital, it's a satellite of Cooper, was that we were transferring a lot of people with that sort of like thought in our minds, that is the patient's status, and there was no way that we could make that diagnosis. So that led to a lot of transfers. We instituted a program led by critical care providers, where we implemented point of care EEG using all of the tools, artificial intelligence, sonification, and raw EEG interpretation, with the support of the local neurologist, right? And we ended up, right, ruling out 9 in 10 patients every single time that we use the technologies, who avoided transfers, and then we made the right diagnosis. What is the uh, importance, right, of making the right diagnosis? Is that you are not going to over treat somebody, and that's also important, right? Is that when you have somebody in status, you have to be aggressive. You have to dump them with everything that you have, right? You have to use everything that you know. But if they don't have status, there is no reason it will not, and the patient will not end up intubated and being hypotensive and that sort of thing. So that's also important. The aggressiveness of treatment will decrease.
That's great. That's great.
And these point of care devices, and we don't have to use any names, are they cheaper than a steak dinner and a movie?
So, so let me tell you. Let me answer how, because I'm the
Yeah.
non-neurologist who doesn't read EEG, and I will tell you, it's a headband that you put on. It says what percent likelihood of seizure, and it saves you money. It saves you money. So every patient we put it on saved money for the institution, decreased the chance that they'd have to be transferred. I think it was really a game changer for us.
Yeah, absolutely.
And do you
I
see
mean,
something
nine,
like
nine
this?
out of
No, go ahead, Fred.
yeah, 9 out of 10 of the times that we use it, right, we ended up with evidence that the patient wasn't in non-convulsive status. So that's actually good.
Yeah, it's a lot to transfer, and I think everyone knows this inherently, but it's a lot to transfer a patient, whether it's the transport or the care that it requires in intra-route. There's danger that happens with transfers, and then of course when they get to the institution, especially with COVID and how busy we are, it's a big strain on the system. So if there's something that you could use to very reliably tell you that this person doesn't need to come to the main center. Again, no offense to the care that they're getting in the main center, but if they're saying the only reason they're coming over is to get an EEG, which they may or may not get immediately, then then why bring that person over in the first place? So I think that's phenomenal. Do you see this as being really the future of care across hospitals, where essentially people can stay specifically for neuro cases in EEG, that people can stay where they are and be managed from a tele point of view, and only when there's significant intervention that actually needs to be done, then and only then they come to the main house? Do you see that as being the future of neurocritical care?
When it pertains to non-convulsive status and seizures, yes. I think it's part of the telemedicine tool box that you have, to sort of like help people in community hospitals, right? Um, to triage their patients. Do they need to get transferred or not?
Yeah, if you can only put this into a robot, I think then you have the complete tele-neuro deployment tool. Everyone loves that neuro robot. Look at Shorna.
Yeah. There's
I
artificial
heard that eye
intelligence
roll over
also.
here.
There's also artificial intelligence in LVOs, large vessel occlusion. So actually, we get an alarm on the iPhone, right, when the machine interprets the presence of LVO. I don't even need to think about like looking at the CTA anymore.
Isn't that crazy?
It is crazy.
That's totally insane.
Crazy.
Let me just double check, Adam. If you have any questions, I also want to make sure that we wrap up on time, and we're getting just to the end of our show. Adam, do you have any other questions?
I want a 15-second answer to this. What do we do as intensivists that drive you as neurointensivists crazy?
And just
Real
remember,
quick.
it's just us here. No one else is
Yeah,
listening.
just-
It's just the four of us.
In terms of status management,
Well,
Anything.
if you want to go bigger, I'll take it.
no, for
Let me ask
status
you-
management.
Let me ask you this: when the emergency medicine physician prescribes 2 of Ativan, what's really going through your mind? What's
Yes, that's what I was going to
That's
say.
exactly right.
The lack of appropriate dosing, right, for the management of status is sort of like what we think is crazy, right? That the guidelines are there, they're written in stone, right, or on paper for everyone to know. People continue to sub-dose first agent medications for the management of status.
So lack of maybe that's why we're not seeing seizure stop in under 60
1
seconds
minute.
because
You got it.
well, that was unfair. I stole that
Yeah,
one.
but-
Anything else because in all seriousness, when you tell us what we're doing wrong, whether it's in the ICU, when I'm working in the ICU or in the ED, it helps me be better. So anything else that you see consistently time after time where you're like, if we could just do this, this would be better for all of our patients.
Swarna.
I think maybe if they're not seizing, and you guys do a great job with this, so it's not really, it's, in general, if everyone could improve,
It's just us,
maybe
Shwarna. You could
if,
say anything.
I know, I'm trying to think.
How about
So
I'll
if
feed
they're
you.
not actually seizing electrographically, to be really aggressive to turn down the sedatives. So it's like less shorter exposure to sedatives. It's hard, right? Because then you need a neurologist at bedside looking at the EEG to say they're not in status. But if we could, get there and get that, then the ideal situation would be to turn down sedatives rapidly if they're not actually seizing. And then that would facilitate earlier SBT and earlier extubation. I try to do that when I'm there at bedside, but it's hard because you really need a neurologist there to look at the EEG to do that continuously.
Well, you need the EEG there to get the neurologist there to read the EEG.
Yeah,
Adam,
that too. Exactly.
I would say in general, right? The question in general, and
Yeah.
this is because of how neurologists think. We think more about differential diagnosis. So not having a differential diagnosis, in my opinion, getting anchored on only one diagnosis can mislead you towards, you may be right on that diagnosis, but not having a differential in a neurological disease, right? For me, it's something that I always think about as a teaching point, right? So if you come in comatose, right, it's not just because you're intoxicated. It could be many things that could explain the lack of normal mentation. So, my teaching point is having a differential diagnosis is actually a good idea, right? When you are seeing this in the emergency department, the hemiparesis, right? What could be? It cannot be only a stroke, okay? It could be something else. And that will give you a better view when you sort of like step out and say, I will work it out and then I will rule out all these diagnoses that may be life threatening. So that would be something that I would say, It doesn't upset me, right? But I find it as a good teaching point.
That's perfect. That's perfect.
That's
Thank
awesome.
you.
Yeah.
All right. Well, I really can't thank you both enough for taking time out of your busy days. I know you're going to be doing some tele-EEG readings right after we hang up this call, so I appreciate you taking time out and chatting with us. Adam, any parting thoughts before we let these good people go?
No, that was wonderful. Thank you so much.
Yeah, I totally learned a ton. So thank you both for being here, and we'll see you at the hospital.
See you
Thank
soon.
you. See you. See you soon.
Adam, another one in the
Episode
books. That's number 4. Four
We,
episodes
we
of
should
the lounge.
we should start doing virtual high fives.
Can we do it? Hang
Let's
on.
try. Okay, let's never do that
Camera's
again.
too far away.
Let's not
That's
do
a
that
good
again.
idea. Let's never do that
that's-
again.
Yep.
But I think we got a good turnout. We had a lot of questions, and it was fun. And, before I forget, if you're watching still, just go ahead and hit the like button and hit subscribe. It helps the algorithm so people can see this. And Michael Bonk, you're welcome. That was great. Look, I just figured out you can put this on the screen. Look at that. Now you can put that on the screen and show all the world that people are watching your show.
And we should say too, all those questions we didn't get to,
Yeah.
time is limited, so I promise
sorry.
we'll get there.
We will answer them offline, but we won't be able to tell you what the answers are. So, unfortunately. So also, I want to make sure that you know that you could reach out to us just through the channel. DM us. If there's an episode that you want to hear, just let us know and we'll make it happen. We are here for you all. So don't forget, like and subscribe. Reach out to us. I don't even know what we're doing next. Do you know what we're doing next in 2 weeks, Adam? Let's make something up.
We had talked about maybe inviting just a speaker to ask questions, not necessarily a topic, but a speaker. I don't know if that's going to come to life, or if we need to find a topic. But what do you think?
One thing for sure, it's going to be as much as a surprise to the audience as it is to us. So that's the good news.
Either way, 2 weeks, Wednesday, 7 p.m. I will be here.
2 weeks. I'll be here too, Adam. All right.
There we
So,
go.
all right. Well, thank you all for being here. We really appreciate it. And from the Critical Care Lounge, we're out. Have a good one.
Good night.